The bill arrives on a Thursday. She's 68 years old, 5 days into a skilled nursing facility stay after a hip replacement, and the number at the bottom of the page is $194 per day. She reads it again, then a third time. Not because she's angry, that comes later. Right now, it's just confusion, clean and quiet. I thought I had Medicare. She did have Medicare. She had a $0 premium Medicare Advantage plan, which she chose because the commercial made it sound like Medicare, only better. What she didn't have was any clear picture of where the real cost was hiding. She spent her career as a claims adjuster, 28 years inside a major carrier's Medicare Advantage operation. She processed tens of thousands of these claims. She watched the confusion arrive week after week in the form of phone calls and appeals and letters that all asked some version of the same question. Why does this cost so much if the premium is zero? She's not here to sell you anything. She doesn't represent any insurer or government agency. She's here because she sat on the other side of that desk for nearly 3 decades, and she knows exactly where the money goes and why switching back to something else may not be as simple as you think. Those are the 2 questions worth holding on to. Where does the money go, if not to a premium? And why can't you just leave? Here's the answer to the first one. Every month, for every person enrolled in a Medicare Advantage plan, the Centers for Medicare and Medicaid Services pays that private insurer a fixed capitation rate, a per-head payment that averaged over $1,100 per member per month in 2026. That's more than $13,000 per enrollee per year, flowing from Medicare to the insurer before you've used a single service. The insurer submits a bid estimating what your care will cost. When that bid comes in below the county benchmark, the government keeps a portion of the difference, and the insurer keeps the rest. That remainder is what funds the zero premium. It's what pays for the dental benefit and the gym membership and the over-the-counter allowance that fills the commercials 30 seconds. The business model, stated plainly, the insurer profits most when you stay healthy and deploys every available cost management tool when you don't. This is not a conspiracy. It is the published CMS-approved mechanism. The $0 premium is not generosity. It is a transfer of risk from the government to you, dressed as a gift. So what does that risk actually look like in dollars? Let's run the numbers on the same person across 3 different years. Same person in all 3 scenarios. 67 years old, single, enrolled in a $0 premium MAHMO in a mid-cost market. Healthy year, no hospitalizations, no procedures. She pays her Part B premium $185 per month in 2026, $2,220 for the year, and nothing else. Total annual cost, $2,220. This is where the plan looks exactly like the commercial promised. This is the number that gets quoted at the kitchen table. Moderate use. Add 2 specialist visits at $45 each. 1 outpatient procedure with $300 co-insurance. 6 primary care visits at $10 each. 1 emergency room visit at $120. That's $2,220 plus $600 in copays and co-insurance. Roughly $2,900 for the year. Still manageable. Still well below what Medigap would cost. Now the hip replacement. Hospital copays run approximately $350 per day for days 1 through 6, $2,100. The skilled nursing facility copay kicks in on day 3, $194 per day through day 7, another $970. Add post-acute physical therapy, copays, and specialist follow-up visits, and the total lands somewhere between $5,500 and $8,500, approaching the 2026 in-network out-of-pocket maximum of $9,350. Compare that to Medigap Plan G, Part B premium of $2,220, plus a national average Plan G premium of roughly $145 per month, $1,740 annually, plus the Plan G deductible of $257. Total, $4,217, regardless of how sick you get. No copays, no coinsurance, no ceiling to worry about. The math is not that Medicare Advantage is always worse. The math is that its cost is unknown until you need it. But here's the part that never shows up in any comparison chart, and it may be the most expensive cost of all. There is a cost that never appears on a bill at all. It doesn't show up in the summary of benefits. It doesn't have a line item. It is called prior authorization, and it functions as a financial instrument, not a bureaucratic inconvenience. In 2026, CMS data confirms that MA plans require prior authorization on services that original Medicare covers automatically. A 2022 Office of Inspector General report found that 13% of prior authorization denials involve services that met Medicare coverage criteria, meaning care that should have been approved was blocked. Inside MA operations, there are teams staffed by nurses and clinicians whose job is utilization management. The claims adjuster's words are direct. I sat 3 desks from that department for 11 years. The metric they tracked was not patient outcomes. It was denial rate and days to discharge. Translate that into dollars. A delayed cancer diagnosis means a later stage at treatment, higher cost, worse outcome, longer recovery. A denied home health authorization means a family member takes unpaid leave or pays privately for care the plan was supposed to provide. An overturned denial after a 60-day appeal means the patient paid out of pocket and may never recover that money. Prior authorization is not a line item. It is a tax on being sick, paid in time, stress, and sometimes in outcomes that cannot be reversed. Now, and this matters, when does the zero plan actually work? There's a comment that circulates on nearly every Medicare video published in the last 3 years. A couple paying $700 per month, combined for Medigap supplements, switches to Medicare Advantage. Their annual out-of-pocket comes in under $700 total. They are healthy. Their doctors are in-network. The math works. Acknowledge it, because it's real. Medicare Advantage is a reasonable choice under specific conditions. When your doctors are confirmed in-network, not assumed, confirmed by calling the plan and the practice directly. When the plan's out-of-pocket maximum is on the lower end. Some plans cap at $2,000 to $3,500 in-network, which changes the risk calculation significantly. When you are in good health and understand that this is a bet on staying that way, and when Medigap premiums in your area are genuinely unaffordable. In Florida, Plan G premiums for a 65-year-old run $350 to $450 per month, $6,000 or more annually before a single claim. For those people, Medicare Advantage is not a bad choice. It is the only realistic one. I'm not here to tell you MA is wrong. I'm here to tell you what it actually is, so the choice is yours. Now the answer to the second question, why can't she just switch? In 44 states, if you enrolled in Medicare Advantage during your initial enrollment period and later want to move to a Medigap plan, you must pass medical underwriting. The Medigap insurer can review your health history and decline to cover you or charge substantially more based on pre-existing conditions. This is not a loophole. It is the standard rule. Picture a 72-year-old who enrolled in MA at 65 because it was affordable. In October, she receives a letter, one she almost doesn't open, informing her that her plan's network has dropped her cardiologist in the annual contract update. She applies for Medigap. The insurer reviews her file. They see the cardiac stent placed in 2019. She is declined. She is now locked into a plan whose network no longer includes her doctor, with no viable exit. Exceptions exist. 5 states maintain continuous guaranteed issue, and trial rights apply in specific situations, but they are narrow and time-limited. This is not a revolving door. It is a turnstile. It moves one direction, and most people don't realize that until they're already through it. Here is a 3-number framework you can complete in 20 minutes. Pull up your summary of benefits. It is required to exist, and it is required to be readable. Number 1, your floor. Part B premium, $185 per month. times 12 equals $2,220, plus any monthly plan premium. This is what you pay if you never use a single service. Number 2. Your likely year. Add up the copays for services you actually use. Primary care visits typically run $0 to $15. Specialist visits $40 to $60. Walk through your prescriptions at your plan's tier structure. Most people can estimate this realistically in one sitting. Number 3. Your worst year. Find your plan's in-network out-of-pocket maximum on page 1 of that Summary of Benefits document. In 2026, it ranges from under $2,000 on some plans to the CMS cap of $9,350. That number is your maximum financial exposure in any single calendar year. It is the ceiling of the second price tag. The framework. If the gap between your number 3 and a Medigap plan's annual cost is less than $3,000, the switching trap and the prior authorization risk may not justify the savings in a healthy year. If your number 3 is under $3,500 and your doctors are confirmed in-network, the math may favor staying. Back to the bill. The woman in the skilled nursing facility, the $194 per day. The zero plan, she did everything right. She enrolled during her window. She watched the commercial. She picked a plan. The zero premium was never the price. It was the advertisement for the price. The real price is written in 3 documents her insurer is required by law to provide: the Summary of Benefits, the Annual Notice of Change, and the Evidence of Coverage. They exist so you can find this information. Most people never read them because the commercial made it seem unnecessary. I spent 28 years on the other side of this. I watch people get these bills and I watch them be genuinely shocked. Not because the plan lied to them, because the plan told them the truth in a font size and a format designed to be ignored. That is the second price tag. It was always there. Now you know where to look. This is an independent educational channel. It is not affiliated with, endorsed by, or connected to any insurance company, the Centers for Medicare and Medicaid Services, or any government agency. Nothing here is legal, medical, tax, or financial advice. Find your summary of benefits tonight. Find your out-of-pocket maximum. Write down your 3 numbers. The worksheet is in the description.